Good morning or good afternoon, depending on where you come from. Thank you very much for your participation and welcome to this webinar about genetic reference studies for clinical gynecology. Today is the International Gynecological Health Day and Genyca is offering you this webinar. Genyca is a molecular biology lab specializing in human genetic testing and focusing in rare diseases, but also predictive medicine and non-invasive prenatal testing. We'll be two presenters today. Myself, Clarissa Miel, I will be presenting the main topics during about half an hour, and at the end we'll dedicate 15 minutes to questions that will be answered in live by Teresa Peruccio, CEO of Genyca. We'll be presenting two types of very interesting genetic studies that have a direct applicability to clinical practice for medical specialists in gynecology and obstetrics. During all the webinar, you can write your questions in the chat box. You can see the chat box in the control panel located at the right of your screen. The order of the topics of the webinar is the following. First, we'll make an introduction, a brief introduction to predictive genetics, and then we will talk about two different studies that we find interesting in daily routine for clinical gynecology. First topic will be the risk of venous thrombosis associated with oral contraceptives. This is a test that you can propose to every woman interested in finding a contraception solution. And the second one is non-invasive prenatal detection of aneuploidies. Obviously, this is a test to propose to pregnant women. We will end the webinar with a description of the action protocol. How do we take the sample? Because it's different in the two tests we are going to present. So, what is predictive genetics or predictive medicine? It is the medicine branch allowing determination of the probability to develop certain diseases during adulthood, and especially it's going to provide an adequate tool with the aim to apply preventive measures. Let's not forget that the main objective is to avoid the disease. And if disease cannot be avoided, delay its onset or lessen its symptoms. We must highlight that every method to predict future diseases is based in genetics. The genetic information we have in our genes is already there. So it's not yet shown, but the information is there. So the better we know the information contained in our genetic background, the better we can adapt the environment and prevent the disease. In this case, what we're going to do is test a woman, the genetic background, by a saliva test, and we are going to try to see if she has a risk to develop thrombosis, and we are going to try to use this information to decide and personalize about the contraceptive solution she's going to use. This is a very simple and visual scheme of predictive genetics. So the objective is to know the patient's genetic background with a genetic test from a saliva sample. This information, genetic information, is going to allow us to change the environmental factor of the patient. In this case, environmental factor, one of them is going to be the contraception, in order to prevent the disease, venous thrombosis in this case. And this scheme can be applied to all multifactorial diseases in adulthood: diabetes, cancer, celiac disease, obesity, cardiovascular diseases, including venous thrombosis risk. So the more we know about the genetic component, the better we can modify the environment with the unique objective to prevent the onset of the disease, the venous thrombosis in this case. This disease we are talking about today is multifactorial disease. I'm going to explain you the two different types of diseases with a genetic component. We have, on the left side, we have a monogenic disease, in which one mutation is responsible for a single pathology. These are determinist diseases. There is a mutation that determines the apparition of a disease. As you see here, 100% of the patients that have the mutation present the disease. This is what we know as rare diseases, infrequent, very aggressive, and they don't affect all the population. Now, on the right side, this is the case we are going to see today, we represent a multifactorial disease, those affecting all the population. The genetic component is polygenic. As you see, we have here represented 4 different genes, and all the genes are involved in the disease, and the effect of each polymorphism is different and cumulative. As you see down here, they don't arrive to 100% because environment also plays an important role. These multifactorial diseases are the most common between the population. As we just mentioned before, it includes diabetes, obesity, cardiovascular diseases, this venous thrombosis disease, and cancer and Alzheimer's, for example. So we are speaking about the multifactorial heredity. We have the addition of the genetic component and the environmental component. The disease only appears when the addition of them both. This cannot be forgotten, that there is a genetic and an environmental component, and in the end it's like playing Russian roulette. The genetic factors would be the numbers in black, and the environmental factors would be the numbers in red. According to what we bet, we have more chances to win the disease. So, for example, we have a patient that comes to gynecological consultation, and maybe she has a strong component, genetic component. But if she controls the environmental factor, for example, the contraception solution, she can avoid the disease, she can avoid the venous thrombosis. On the opposite case, these multifactorial diseases, the people that present very light genetic component can be exposed to so many environmental factors that can affect them and then develop the disease. Now we are going to apply this to the risk of venous thrombosis associated with oral contraceptives, which is what is going to interest you. Cardiovascular diseases, as you all know, are a group of heart and blood vessels disorders, and they include hypertension, thrombophilia, venous thromboembolism, dyslipidemia, and ischemia. They affect many middle-aged people, so working-age people, and are the leading cause of death in the world. According to the World Health Organization, 31 of registered deaths worldwide are due to cardiovascular diseases. So, venous thrombosis risk is a set of 2 conditions. We have deep vein thrombosis of the lower extremities, which are due to thrombus formation in the deep veins, and they can be preceded or followed by vessel wall inflammation. This, we don't know it. If they are preceded or followed, we don't know it in advance. And this can end up in pulmonary embolism, which is the result of the detachment of the thrombus and its arrival in the pulmonary artery, which eventually clogs. Venous thrombosis is one of the main causes of morbidity and mortality. It has a very high cost of hospitalization because this is people which are actively working. They stay weeks at hospital with heavy treatment and resting. There's a high probability of recurrence. It goes up to 15% of hospital deaths, and 25% comes to sudden death. That's why we really have to take this seriously. What are the causes of venous thrombosis? They are environmental, and there we are going to include the immobility, surgery, trauma, aging, cancer, pregnancy, postpartum, use of oral contraceptives, or even hormone replacement therapy. And there are also genetic causes. Mutation 5, factor 5 laden, and factor 2 laden. They both increase the hypercoagulability and they favor hypofibrinolysis. And now we're going to really focus in the genetic part of the story, and these two genes, factor 5 laden and prothrombin, which is factor 2, I mentioned before. Each of these two genes, factor 5 laden or prothrombin, can be dominant. The patient then can be heterozygous or homozygous for each of the genes. But each of them gives a different risk to the patient. It is worse to have the mutation of factor 5 laden in homozygosis because the protein will not be synthesized and the patient will have a higher risk to produce thrombus, and it's going to be 80 times higher than the general population. This is enormous. If the gene is in heterozygosis, as the patient has only 4 to 7 times higher possibility to develop it than normal population. And if we look at the prothrombin gene, the risk in heterozygosis is 2 to 4 times higher than normal population. Using oral contraceptives and being heterozygous for factor 5 laden increases the risk slightly compared to each factor separately. But if a woman is taking oral contraceptives and she's heterozygous for prothrombin mutation, the risk increases. For this reason, it's highly recommended to do this genetic study of these two genes before starting a treatment with oral contraceptives. Because the gynecologist is going to be able to personalize the treatment. Sometimes we'll recommend not to use oral contraception, and in other times he's going to direct the patient to one or another oral contraception. I just want to say something which is very curious from the genetic point of view. It's a semi-dominant inheritance. It's very curious. This is called semi-dominant because the mutant homozygous has a higher risk, this one, than the heterozygous, and this one is higher than the normal homozygous. It is not a dominant heredity. That will be the first presenting the pathology, and it's not recessive. That will be the last will present the pathology. In this case, also in the middle, we have a different one, the heterozygous. Let's speak a little bit more about oral contraceptives. These are the leading cause of venous thrombosis in young women, and mainly because the coagulation factors increase and the clotting inhibitors decrease. Antithrombin, protein S, increase resistance to activate protein C. When together with this, we add the oral contraceptives, the risk is huge. Very often we have the gynecologist will ask the patient if there are family cases, but the problem is the patient very often will ignore the existence of a family history because normal population does not know the terminology or because we simply don't speak about this pathology between family members. So asking patients about family history is not enough. Really, the genetic study is necessary. The use of oral contraceptives was also strongly and independently associated with the disorder. The factor V Leiden and the prothrombin mutations have been known to be common genetic determinants of deep vein thrombosis of the lower extremities. This is very strongly sustained by scientific bibliography. What are the objectives of the genetic study in this case? First of all, a personalized treatment. The gynecologist is going to obtain better adhesion, more effective, cheaper, and he's going to find the right treatment. The treatment is not going to be risky for the patient. Like that, he's going to give the patient prevention, pharmacology treatment, monitoring. These are the basis of really personalized medicine. And today, patients always want more. Then, secondly, and not less important, is going to prevent associated pathologies. And the last of the three is family studies. If there's a patient with susceptibility to this disease, it will be good that all the women relatives they do the study. What is the inclusion criteria? Who is going to be recommended this test for? Family history, of course, but we know that sometimes family history is not easy to discover. Vascular disorders already present, like varicose veins in legs, thrombophlebitis, arterial hypertension. Also, hematological abnormalities we're going to find in biochemical tests, like hyperhomocysteinemia, coagulation factors, chest pain or microinfarction, and of course, women starting treatment with oral contraceptives. We have brought a clinical case in order to illustrate with a direct clinical application what we have seen today. The case is striking but very common. So we have a woman 33 years old with varicose veins in legs and pain in extremities and repeat abortions. This lady had 3 children and she had also 3 abortions. And her father had a pulmonary embolism at age 65, but this he had it after the patient did the test. So she didn't know about this family history. Genetic result, we take a saliva sample to the patient. 1 week after, we obtain the result, and we find variants present in both genes, in factor V and MTHFR. So the recommendations are, from the gynecologist, prophylactic treatment with anticoagulants in risky situations, not all the time, when she has a sedentary lifestyle. For example, she breaks a leg and she has to stay resting, or when she goes through surgery, and then avoid taking oral contraceptives. Now I'm going to present you the second test, which is recommended not of course for any patient. This is for pregnant women. We all know that amniocentesis, you know it even better than me, involves a risk of abortion. The risk depends, of course, on many things, such as the technique, the person performing the amniocentesis, the patient, it is high-risk pregnancy, but we all know that there is a risk. So what we are going to do is apply new genetic knowledge in order to minimize the risk of an invasive technique and propose non-invasive prenatal studies. What are the basis of this NIDA test? NIDA is for non-invasive prenatal detection of aneuploidies. There's free fetal DNA in the mother's blood. The mother's blood, we're going to call it peripheral blood. So in this peripheral blood, we find the mother's DNA and also the free fetal DNA. What we're going to test is not the entire fetal cells, but fragments of fetal DNA in the mother's blood. The fetal DNA, you're going to see, is going to increase all along the pregnancy. At the beginning, we have a very small proportion, but it increases all along. And at birth, it's going to decrease dramatically. In total, it is a small quantity, lower than 9 to 20% of free circulating DNA. In addition, this free fetal DNA degrades very easily because it is not protected. Remember, it's free, it's not protected in the cell, it's out of the cell nucleus, so it's exposed to nucleases. Nucleases are enzymes that cleaves nucleic acids. And these nucleases are present in the blood, in the mother's blood. So due to this, the free fetal DNA must be processed, if possible, during the first 24 hours because it rapidly degrades. What are the advantages of this NIDA test? First of all, we have now the possibility to obtain fetal information by using a non-invasive technique. And as a consequence, the risk of fetal loss by invasive procedure disappears. We avoid trespassing the placenta. We're avoiding the amniocentesis. Important is that the concentration is going to increase along the gestation. So if we go a little bit longer, a little bit later, we have more concentration. But we don't want to go too late either, because we're going to be taking decisions. Of course, there are also drawbacks. Inconvenience would be that we have a small amount of fetal DNA. We have seen in the other slide. The proportion of fetal DNA and comparing to maternal DNA is low. This fetal DNA is fragmented into small pieces, and the fetal DNA is mixed with DNA of maternal origin. So this makes that the technique is complicated. Let's understand this test a bit better. So NIDA is a non-invasive prenatal test that is going to detect the presence of the main aneuploidies in the fetus, what we are usually doing by amniocentesis. But this study is safe because we are not taking a sample from the baby. We are not trespassing the placenta. It is simple because we are just extracting some blood from the mother, and it is reliable. What we are doing is counting chromosomes. For example, if we have 4 chromosomes 21, we know that 2 are coming from the baby and 2 from the mother, what is normal. But if we find 5 chromosomes 21, we have 1 extra. And because we know the mother's phenotype, she has no Down syndrome, we know that it's the baby that presents the syndrome. So this test is going to analyze the free fetal DNA in maternal peripheral blood with the objective to detect chromosomal aneuploidies in the fetus, and is going to allow discarding the presence of various syndromes like Down syndrome, Edwards, and Patel, among others. What can we exactly detect with this technique? We are going to detect many things. First of all, autosomal trisomies, which are variations in chromosomes number, for example, trisomies. For example, trisomy 21, Down syndrome, we know is characterized by mental retardation, multi-organic abnormalities, and it appears in 1 in 800 births. Trisomy 18, which is Edwards syndrome, characterized by serious malformations and perinatal death, and it's 1 in 5,000 births. Trisomy 13 Patau syndrome, characterized by, same thing, serious malformations, perinatal death, 1 in 5,000 births. And the novelty this year, or the improvement in the NIDA study, is that we can also detect the trisomy 9, trisomy 16, and trisomy 22. What else can we detect? We can also detect anomalies in sex pairs, abnormal sexual development. And this is 1 in about 300 to 400 births. So what do we have here? We can detect Turner syndrome, Klinefelter syndrome, but also XXX and XYY. And we can also detect the presence of deletion syndromes. Deletion is when a piece of chromosome is missing. So we have the Genyca syndrome. This piece is missing. We have deletions in chromosome 1, chromosome 2. We have the DiGeorge syndrome. We have deletions in chromosome 16, the Jacobsen syndrome, van der Waals syndrome, Prader-Willi-Engelmann syndrome. And what happens with all this when we have the result? If the result is negative, neither result is negative, we can rule out all these pathologies we have seen. But if the result is positive, as it is a probabilistic calculation, the test has to be done, an invasive test has to be done to confirm the result. But remember that we have already avoided the amniocentesis in all the results that are negative. So summarizing, NIDA, there's no risk for mother and fetus, no risk of abortion, no risk of infection for the mother, intrauterine infection. Then it can be performed from week 10th of gestation. The detection is above 99.5%. It only requires 10 milliliters of peripheral blood. It is valid, important, these are two last points, valid also for twin pregnancies, and it's suitable for egg donation. Even if the mother is not a donor, we can perform the test. So now that we have seen these two tests, you can propose in gynecological obstetrician consultation. We can see the action protocol. So how the sample is taken, and it is different in the two cases and the two tests I have explained. We start with the first one, which is the risk of thrombosis associated with our contraceptives. And first thing I want to tell you is that the sampling is very simple. It is done from cells from the oral mucosa. We often call it saliva sample because we want the patient to understand that the sample is not going to hurt. We are not going to make a biopsy. We're just going to scratch. We're going to, with a swab, a cotton swab, in the inner part of the cheek. We use a sterile cotton swab, which comes in our protection case. We should open the package, breaking the security seal, and we remove the swab. We take it out without touching the end, the cotton swab, which is the part we're going to put in the inside of the mouth. We insert the cotton swab inside the mouth and we rub up and down the interior of one cheek, at least for 1 minute, and we press firmly. We're going to use 2 swabs per each patient, and we are going to use each swab in a different cheek. We are not going to need the 2 swabs. In reality, we will make the test from 1 swab, but if there's any problem, if there's a contamination or not enough samples, then we will use the second swab, and we don't need to call the patient again to make another test. That's why we always take 2 swabs. You place it back in the protective tube. You identify it outside with the patient's full name. You seal it with adhesive tape or similar, and it's ready to send. Important, patients don't need to be fasting, but please remind them they need to have a clean mouth. So 1 hour before the sampling, they don't eat, they don't drink, they don't smoke, don't eat chewing gum, and they have a mouth washed and clean teeth. Those are the recommendations. Now we are going to talk about the sampling for the NIDA test. This sample is peripheral blood. So it's this sample, the blood of the mother is going to be taken directly in this special Streck tube. 10 milliliters of the patient's blood. We should feel it full. This Streck tube is special because it has an anticoagulant that is going to preserve the fetal DNA the better and longest possible. Once we have the blood filled full in the tube, we gently rotate the tube up and down, upside and down, because we want to mix the blood with the anticoagulant, and then we keep it upright, in upright position at the end. Same thing, we're going to identify the tube with the patient's name, and we send it immediately to Genyca. You remember, because we said that this fetal DNA is going to degrade very, very quickly. So we need to send it fast. Patients, in this case, they don't need to be fasting either. With all genetic tests, we have to, the doctor has to fill the request form, just fill the patient data, what is the test is going to request, and in the back of the request for service form, there's an informed consent statement, and this is to be signed by the patient. This is important to send the tubes or the swabs together with this document. This is the general protocol. The patient goes to a first consultation to the gynecologist or obstetrician. They are going to do the test, the sampling. Then the doctor, especially, is going to send it to Genyca by courier. And not a long time later, we are going to see in the last slide how long does it take, the results. Genyca will send them back to the doctor by email with a protected password. So only the doctor is going to be able to open the results. And then the doctor, in a second consultation, is going to see the patient, explain the result, and give the advice. What are the advantages of the genetic testing? The first is thrombosis risk. The patient is going to know her own genetic background in this case, and she will, I'm sorry, there's a mistake here, is going to change her habits, adapt together with the doctor, the treatment, the contraceptive treatment. This is the second part. The treatment is going to be personalized in order to save, to avoid the patient to develop the thrombosis. This is going to be a new prevention tool, and it's very useful information for relatives because they share genetic information, so they can know their predisposition and prevent associated pathologies, vascular pathologies in this case. The specialist is going to have a personalized treatment individual for the patient. It's going to increase the motivation of the patients. They have a new tool, and they stay at the forefront of analytical technology. Knowing about family history, when we have a genetic test that is going to give us a result that is in our genes, that it doesn't change, and that can personalize the treatment. This is very valuable for the doctor. The results of patients, both clinical and genetic, can be presented at conference or scientific meetings because they are considered as innovative routine practice. And the latest of the advantages for the specialist is that the saliva sample can be taken at the specialist consultation, and then the result in this case is back in 1 week. Working with Genyca, in both cases, the saliva and peripheral blood, the sampling is easy. There's non-invasive in any of the cases. It's convenient because you can done at the consultation. It's unique. The results and for the thrombosis risk are valid for life. They don't have to repeat it. The result for NIDA is valid for the pregnancy. Innovative, stay at the forefront of technology, and familial. This is to avoid diseases in relatives. To finalize, I'm going to make a summary of what we have seen. We have seen 2 different genetic reference tests that are useful for daily clinical practice in gynecology and obstetrics. The first one, the risk of thrombosis associated with oral contraceptives, is recommended to women that need a contraceptive solution. It's taken from an oral mucosa sample and results in 1 week. Sorry. Then the second one, non-invasive prenatal study, recommended for any pregnant woman who like to test to find common chromosomal aneuploidies in the unborn children, and very especially older pregnant women or women with high-risk pregnancies due to other medical reasons. This is peripheral blood sample avoiding the amniocentesis, and the results are in 15 working days, which is around 3 weeks. Now, I thank you very much for your attention, and we are going to start 15 minutes dedicated to questions. So you will find in the right side of your screen a panel with a chat box. I'm going to change the presentation, and it's going to be my colleague Teresa that is going to answer these questions in live. The questions you have to write them in a chat box, and she will answer in live with voice. Teresa, it's your turn.
Thank you very much, Clarissa. I hope you understand and listen me well. If you have any question, I can answer it. I have answered the question right in the chat, so I don't know if you have anyone else.
Teresa, I don't know if you have answered, but I have a question. What is the gestational recommended age for the NIDA test?
It's better to do it from 10 weeks. The amount of DNA, of fetal DNA, that is in the blood of the mother is not enough if the baby is less than 10 weeks. So 10 weeks is the limit of the age of the baby to do this test.
There is another question. How can the NIDA test analyze the chromosomes if the fetal DNA is fragmented?
I don't listen you so well, Clarissa. Sorry, can you repeat the question, please?
There's someone asking, how can the NIDA test analyze the chromosomes if the fetal DNA is fragmented?
we isolate the DNA from the blood matter, and we make a general sequencing, a new generation sequencing of the fragments of the DNA, and we analyze each fragment of the fetal DNA.
Okay, that is because we are not looking at entire chromosomes. That's it. We are looking at the DNA. So even if it's fragmented, we are looking at fragments with specific probes.
Yes. Yes. In the DNA is fragmented already, but we can analyze it, and we can make a prognostic and know how is the number of chromosomes of each of them.
Maybe you can just read out loud the question you had during the webinar.
I don't have them now here. I don't know if they can write anyone else, or
Anyone has a question? Because there have been questions sent by written during the webinar, and Teresa has been answering them one by one. So if you have any more questions, you can send them to the emails that you find in the last slide, to Teresa or to myself. And thank you very much, all of you, for your interest. And we look forward to receive your comments and questions. You can send us technical questions or ask for pricing, and you're very welcome.
Thank you very much for all of you.